Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast. We have a guest today. Her name is Adair Anderson. She's a registered and licensed dietitian nutritionist. She'll tell us what that means in a second here. But we're going to talk about gut physiology, and we're going to talk about a test called the gut zoomer test, which is a test I use pretty frequently. And Adair not only probably uses this test in her practice pretty frequently, but also is kind of an advisor with Vibrant Labs, who's is the company who actually produces the test. So Adair, welcome to the Thyroid Answers podcast. How are you today?
I'm doing well.
So I guess the place to start is just to have everybody get a little bit of background about you. Who are you, what you do, and how did you get into working with Vibrant Labs and being here today to talk about the gut zoomer test?
Yeah, great question. So, I'm a dietitian nutritionist, got the private practice, but also wanted to get involved on the lab side of things. And one of the women that I've looked up to in terms of educating people on evidence-based stuff, Dr. Mary Beth Augustine, worked at Vibrant, and there was an opening for position on the clinical team, and I jumped at the opportunity to learn more about lab testing. So I've been with Vibrant for over 4 years now, and did such a good job in the clinical team. They've brought me over to the marketing team. So now I'm the product marketing educator, where anytime we launch a new test, I get to explain that test to not only everyone internally at Vibrant, but also all of our clients, all of the healthcare providers who order Vibrant testing. So it's my job to learn the ins and outs of all the tests.
So let's talk a little bit about GI testing, maybe why it's important. From a medical standpoint, we typically think about the GI tract. Is there a problem in the GI tract? The testing that is typically done in a gastroenterology practice is a bit different than functional-based testing. So can you touch base? Hey, what's the standard difference between what a gastroenterologist is going to look at versus what some of these functional tests look at?
Yeah, so most gastroenterologists are going to be trying to diagnose something. So they're looking for elevated calprotectin to diagnose ulcerative colitis, Crohn's disease, that there's actually a change to the mucosa and it's like actively bleeding. If there's like occult blood, for example. You can also do a oocyte and parasite test, an O&P, to look for actual parasite in the stool, though that is often falsely negative because they're stealthy and you can't always find them. In contrast, a functional stool test is going to look at pretty much everything within the gut microbiome. Well, specifically within the colon. It's a stool test, stools in the colon. And so in terms of Vibrant's gut zoomer, we're looking at 150 commensal microbes, 76 pathogens, along with gut metabolites, digestive markers, gut antibodies. It's a really comprehensive look at exactly what is going on within the whole gastrointestinal tract tube. So are you digesting? Are you absorbing? Do you have a good balance of flora? Is your gut barrier intact? Do you have enough secretory IgA? Do you have enough Akkermansia to help balance the mucin layer, the mucus layer that is part of that barrier? Do you have leaky gut or not? Like, do you have intestinal hyperpermeability, for example? So it gives you a deeper insight into, what's really going on and getting to the root cause of what could be causing the eventual disease, but also in a preventative sense, gives you insight before that happens. You can prevent that ulcerative colitis or Crohn's disease from actually manifesting.
Yeah, and I'll add to that a little bit to even maybe from my perspective, just simplify it for the listeners a little bit more. When you're seeing a gastroenterologist, as Adair was saying, they're looking for a disease, a pathology that they can cut out or medicate and say, okay, you have X disease. And there's things called the Rome guidelines that they utilize for how they evaluate, assess, and treat. If you have no active pathology that makes sense based on the guidelines to cut out or medicate, you will typically get diagnosed with irritable bowel syndrome or something along those lines. Your bowel's irritable. We can see some redness maybe on a pathology-based evaluation, but there's no pathology. There's no disease. Although we would say if there's redness, inflammation, erythema, like there is something, but the disease has not developed quite yet, right? So when we do a functional GI test, I should finish that. If you go to a gastroenterologist and they do a pathology-based testing and it's all normal, you'll get diagnosed irritable bowel syndrome. You'll probably be provided maybe some symptomatic support, and then you'll be told to come back next year and we'll do another assessment, and we'll keep looking at these pathology-based tests until we find the pathology. And then once we have the pathology, we'll either cut it out or medicate you, and then we'll manage the condition into perpetuity. What we're doing with functional medicine, or what we should be doing with functional medicine, is exactly what Adair said. Why wait for the pathology to develop if we can measure the functionality of the GI tract? Is there inflammation? What inflammation markers are elevated, and what can we learn from those markers? Is there decreased digestive capacity, and what might we start thinking about as to why the digestive capacity is reduced? Is there already permeability starting to develop, damage to the intestinal lining that's starting to develop, and what can we do to intervene? And then what's going on with the bacteria in the gut, and how might that be related to your signs, your symptoms, and what we might see on an exam, and not just on a gut Zoomer test or a GI test, but how does that reflect into like a good comprehensive metabolic panel? And especially because the people on here are people typically struggling with thyroid related issues. I talk about this all the time, how gut-based issues are such a big problem for people who have thyroid and immune regulated disorders. Reduced T4 to T3 conversion. People say we just woke up one day and forgot how to do it. Your cells and tissues did not forget how to do it. It's usually an adaptive response to some type of inflammatory process going on. And we can dig into that fun stuff later. But the important part here is when you go to a gastroenterologist with your GI-based symptoms, they are doing a different assessment than what we're doing with these tests. I often do the tests, and if I see something that I think needs a physical evaluation, a medical evaluation, I'll say, hey, take these results, my notes to the gastro. I think we need to get an evaluation done here just to be on the safe side. And they'll often say, I don't even know what these things are. I don't run these tests. They'll do a pathology-based test and say, there's nothing going on. I don't know why you're here. But we don't want something to occur, and they're not running these tests on a regular basis. Therefore, they really don't have a knowledge base about what all these things mean. And so that's part of the discussion today is, why would we do this test, and what do these things mean? You okay with all of that?
Sounds great.
So functional GI tests, there's lots of them on the market. And I've been in practice 30 years, so I've seen lots and lots of functional GI tests. But the Gut Zoomer is the test I run exclusively at this point when I want to initially evaluate what's going on with gut and gut physiology. What sets the Gut Zoomer test apart from all the other functional based GI tests that are on the market? Because sometimes people don't know. They say, well, I had a GI test done, I had this one done, or that one done, or this one done. But what's your stance on why this test is maybe the best test to run on somebody if we're looking at the functionality of the GI tract?
Yeah, so the reason the Gut Zoomer is sort of a step above the others is because we use the most evidence-based gold standard methodology for identifying what is on the test, all of the markers. For example, for identifying commensal bacteria and pathogenic bacteria, we use real-time polymerase chain reaction, or RT-PCR. And in addition to that, we also do bead beating, enzymatic and thermal processes to get rid of any biofilms to really get to the nucleic acids in order to identify those specific microbes. And we also use not only 16S, but 23S and also proprietary sections. If you only use 16S, and you give a company 20 different microbes just running 16S, you might end up seeing 80 different microbes. Whereas when you're using 16 plus 23 plus proprietary mechanisms, you can accurately identify those microorganisms. Certainly with pathogens, like they're known things. Like with E. coli, we know exactly what to look for, and so you only need a couple of probes for pathogens. But for commensals, there's so many of them. We have proprietary ways of identifying exactly that organism. So we know it's very accurate and precise. In fact, our gut pathogen study showed a 100%, oh gosh, I can never remember, sensitivity or specificity. We got a 100% specificity and a 95.9% sensitivity, meaning no false positives. If you have it, you have it. If GutZoomer says you have this pathogen, you absolutely have it. There's a small chance we've missed it, but if it says you have it on the test. And then in terms of the other methodologies, we're using LC-MS/MS, liquid chromatography, TNM mass spectrometry, which is a gold standard for identifying small molecules. We are using that for all of our bile acids, short-chain fatty acids, fecal fats, meat fiber, vegetable fiber. And then we're doing our proprietary chemiluminescence microarray for all of our gut antibodies. So tissue transglutaminase, deaminated gliadin protein, anti-gliadin, anti-actin, anti-LPS, and also anti-Saccharomyces cerevisiae antibody, or ASCA. And I can totally dive into that, but that's like a
I think it's still that's a little too, we don't need to go that deep, I think, for some of this, because there's a lot of people are going, I don't even know what those things mean. So we'll kind of scale it back a little bit. But there are some tests that are available on the market. I'm not going to mention names, but people go and get these tests done. They're direct to consumer tests. And when I have an initial conversation with somebody, they're like, oh, I had a functional GI test, and I'll get a test and it's just a bunch of bacteria on there. And they're like, this is my gut test. And maybe it's got some genetics, and here's the recommendations I was given. My challenge with those tests is, A, I'm not sure how accurate the information is. B, it's just the biome, potentially, right? It doesn't tell me how well are you producing pancreatic enzymes to help break down and kill the bacteria and the food that's coming in. It doesn't tell me anything about fat malabsorption or lack of absorption of fats, right? It doesn't give me an idea of the intestinal lining. Is that starting to become problematic? There's a lot of things that aren't on those tests that are, from my perspective, are critical to helping our clients. Just looking at the bacterial balance, looking at the bacteria there, I don't know if it provides me with as much information. That biome can change pretty rapidly many times. And so it is sometimes, I think, the argument I hear from people in the allopathic world, like, the biome changes all the time. It's a ridiculous test. But the biome stuff that we see on the GutZoomer, we get information from it for sure, but I'm not looking at only the gut biome. I look at the gut biome and say, okay, why is this the biome that this person is developing? And all of those other functional tests are important. So do you see a challenge with some of these direct-to-consumer tests that are just providing bacteria and then providing recommendations based on just the bacteria that's there?
Oh, absolutely. Yeah, if you're just looking at the bacteria, like as you said, it can change rapidly based on what you eat. For example, if you take a vacation to a tropical place and they're eating lots of pineapples and guavas, like the fruit-loving bacteria will grow in numbers because you are feeding them. And then as soon as you go back home and start eating your meat potatoes, like those bacteria that were thriving on fruit will die because you're no longer feeding them fruit. Like it can change very rapidly. And so when you want to look at what's going on in your microbiome and how that's impacting digestion, absorption, and inflammation in the gut, you really want to start top to bottom and look at anything that could be going on. So starting again, thinking about the GutZoomer from the top of the GI tract from your mouth to your anus, like first you want to make sure, are you digesting your food, right? The GutZoomer is going to look at pancreatic elastase. It's going to look at bile acids. It's going to look at fecal fats. So are you digesting your food? And are you able to break it down in terms of fat breakdown through bile? After that, you want to see, are there a lot of good bacteria populating your gut? So for example, is it easier to build a house in Manhattan or the middle of Montana? Where is there more real estate, right?
Hmm.
Probably in Montana. There's more land available to build. Maybe money aside, right? Not thinking about that piece of it. But the fact that Manhattan is already populated, every square inch is covered in some type of concrete, harder to build there. So we want a microbiome that has lots of good microbes, commensals, we call them. We want lots of commensals because that way, if a pathogen comes in, it's not going to find real estate. It's not going to find a place to build, to live. Whereas if you have low commensals, if it's like a barren wasteland, like there's nothing there, anything can grow there. An example is that my friend went on a camping trip and used a little too much iodine to clean his water and ended up wiping out like all of the microbes and then got a Clostridium difficile infection because there was nothing to compete and prevent that from happening. And C. diff is awful, so don't recommend doing that.
Well, we'll touch base on that. We'll get back there. I do want to touch on one other thing you said
Yeah,
regarding the testing, and
yeah,
it was regarding the biofilm breakdown. And I think
yeah.
this is really important. And years ago, when one of the more popular functional tests came out, kind of new on the market, more markers than maybe was out there on previous testing.
Mhm.
And I ran a test on somebody, and then I provided an enzyme, a systemic
Mhm.
enzyme, and
Mhm.
then there was a problem with the collection. We collected a kit about a week and a half later, and we get the new test results back. And the bacterial balance, there's a lot of difference there, lots of difference
Mhm.
there. And
Mhm.
so I'm like, what is going on here? And this is maybe more than a decade ago. And so I was like, what the heck? And then I spoke with somebody. I reached out to a biologist and I said, hey, what do you think would create this? Because I had reached out to the company and they're like, they gave me a bunch of comments, but none of them seemed to land appropriately. And he said, well, you provide a systemic enzyme. You probably broke down the biofilm. You should be doing that before every test anyway, right? I'm like, no, like I wasn't at the time. Nobody was mentioning, hey, we should do this. And so it became the thing that I started doing. I don't do a lot of the other testing companies do what you guys do to try and break down biofilm prior to
Mhm.
collection.
Mhm. Yeah, I can't speak to what other companies are doing. I just know that we make sure to do these thermal, mechanical, and enzymatic processes. So the bead beating, literally beating like with beads in a bead beater, like moves them around, knocks them around. So it breaks down that biofilm. It breaks down biofilm is sort of like the microbes building a home for themselves. It's like this little raft where anyone can go and live, and then they have this community. It's sort of like a commune, but you want to like break that down and pull it apart so we can actually get and identify what's in that, what's stuck inside the biofilm. Otherwise, it could be things could be hiding in there, like yeast, for example. So bead beating mechanically breaks it down, literally pulls
Mhm.
it apart, sort of like chewing your food, mechanically breaks down your food. And then enzymatically, anytime you add an enzyme, it's going to also break down those compounds. And then thermal processes is heating it as well. So when you heat something, it can also break it down. Like it can soften vegetables when you cook them, right? They're no longer crunchy, now they're soft and mushy. Like that's what we're doing to the biofilms. It makes it a lot easier for it to disintegrate into a liquidy substance so that when we do the polymerase chain reaction, when we're putting all the enzymes in there to make amplification happen, they can actually bind to the target because it's not getting stuck
Yeah. And so this
in
is
that
for the
hidden.
listener, this is really important because almost all the organisms have this biofilm. It's their kind of protective coating. It's like me sitting in my office. Nobody knows I'm in here, right? They can hear me maybe, but the immune system, if there's bacterial overgrowth, the immune system sometimes can't see through those biofilms to get at the organism. So you could have all kinds of signs and symptoms, but if you're doing a test and you haven't used some type of systemic enzyme or biofilm disruptor prior to testing, or the lab that's doing the testing isn't going through that process to mechanically break down or enzymatically break down that biofilm, you may not see what might be contributing some of the immune-based challenges that are going on and maybe some of the signs and symptoms, right?
Exactly.
So I want to talk about commensals and pathogens, okay? Because these terms may not be familiar to everybody. And the way I explain it is commensal bacteria aren't necessarily good or bad, but they're like the neighbors in my neighborhood. There's 114 homes here. Everybody who owns a home here deserves to be here, okay? But if I've got one of my neighbors likes to party a lot, likes to invite everybody over, and they're partying until, you know, all hours of the morning every night, even though they are part of the neighborhood, it is going to potentially create a problem for me, right? And if I have another neighbor who loves to live in their vacation home in Florida 7 to 8 months out of the year, and that means those 7 to 8 months out of the year, they're not taking care of their property, it becomes disheveled, it doesn't look great, the grass is growing too high, and it too can become a problem, right? So sometimes people think I either have pathogens, and that's a problem, that these commensal bacteria, which are bacteria that are supposed to be there, can't be a problem. So let me have you just kind of break down, what do we consider a pathogen? What are commensals? Are they good? Am I wrong? Are commensals only good, or can they also be problematic?
Yeah, great things to break down and nuance apart here. So pathogens are things you do not want. For example, Clostridium difficile. Like it causes illness in your body. It causes whatever diarrhea or gastrointestinal upset. These are things that don't provide any benefit, and they shouldn't be there, right? They're not supposed to be there. So pathogen, when you get it, you want to get rid of it most of the time, unless it's self-limiting, but that's another conversation. In terms of commensals, you can have a probiotic commensal, which provides benefit to its host. So these are probiotics like Akkermansia or Faecalibacterium presnitzii or Roseburia that create short-chain fatty acids or create vitamins like B12 that help us as the host to give us benefit. And then, as you said, there's also just bacteria that live in existence, like in the neighborhood. However, sometimes they can get turned to be a more pathogenic strain because of what else is going on in the environment. So, for example, when someone is acting out poorly, like in a elementary classroom, like it leads more kids to also act out, and it sort of changes the mentality of those microbes to be more on the not pathogenic side, but like on the bad side, to be more
problematic.
Problematic. That's a good word. Problematic. And also sometimes when you have too much of a particular bacteria, for example, when you have too many lipopolysaccharide producing bacteria, too many of the gram-negative bacteria from the proteobacteria phyla, that causes more inflammation in the gut because LPS is inflammatory. It can cause endotoxemia after eating. It's actually what causes sepsis if you get an infection like in an organ outside of your gastrointestinal tract. So the balance of microbes is also really important.
Yeah. And we call that the diversity, right? And we see that there's 2 indexes on the gut Zoomer test, and those 2 indexes give us some idea of like how many different types of organisms, of these commensal organisms we have, and how balanced they are in between each other, right?
Exactly.
And we won't necessarily break them down, but that part's important. If we see that you have lots of commensals, but the diversity is not very good, then that can be one of the reasons why we have some signs and symptoms, correct? So in a standard allopathic approach, they're typically not looking at the commensal bacteria at all, correct? From my knowledge base, they're typically really just looking at pathogenic organisms only. And I think the reason, from my perspective, that they don't look at the commensals is because they don't really have a strategy to address commensals. So we don't address them, right?
Right. Exactly.
So when we are looking at inflammation in the GI tract, well, let's keep on the dysbiosis standpoint. a lot of times people are, I think, confused a little bit. Like, how could I have bacterial imbalance? Like, where is it coming from? And we probably need to talk about that a little bit. Like, what is the primary thing that leads to an imbalance? Let's just talk commensal bacteria.
Mhm.
What are some of the primary things that would lead somebody's commensal bacteria? These are the bacteria that should be in the GI tract, most of them in the colon. But what would cause these bacteria to be dysregulated?
Oh, yeah. The number one cause is probably not eating enough fiber-rich foods, not eating enough plants.
So there's a
Because,
whole community that would argue with you on that, right? You know that, right? So, um, but why would plant-based foods? Because that community would say plants have toxins, toxins damage the GI lining, therefore plants are bad. You should not eat plants. But let's talk about why fibrous-based plants could be beneficial to the gut and the GI tract.
yeah, I'm solidly in camp fiber over here for sure. So come after me if you want, folks who believe the other side. But yeah, so what feeds our short chain fatty acid producing bacteria are prebiotics, fibers, polyphenols. These all come from plants. Our microbes will take these undigested carbohydrates and things and turn them into short chain fatty acids. Short chain fatty acids are essential for the gut lining. They heal and seal the gut. They help produce new cells. There's a study that showed people who had higher short chain fatty acid levels had better COVID outcomes. Like short chain fatty acids are really important. It is like the number one source of fuel for your colonocytes. I mean, you don't have enough of them. Your colon cells are literally starving. And eating plants is what feeds these good microbes, feeds these commensal microbes.
Yeah. And so I'm in agreement with you, but I'll take the other side of it as well too.
Okay.
Okay. So for the listener, like if you already have a lot of gut based issues going on, you have a lot of signs and symptoms and issues going on and a lot of inflammation in the GI tract, there is a truth to the fact that plants have some level of toxins in them. My belief is that primarily when we eat healthy, properly raised crops and we eat them in season when they're ripe, they have a lower level of toxicity. That's probably not problematic, but plants don't have much of a way to defend themselves. So having higher level of toxicity when they're not ripe protects them in nature. We have a tendency to pull our crops way before they're ripe. We force ripen them in a factory somewhere so they look beautiful and we eat them. But that doesn't necessarily mean that the toxicity of the plant is gone because we force ripened it. It may still have a higher level of toxicity. But even those toxins in the plant have a benefit in a healthy GI tract. They are like exercise for the immune system of the GI tract. If you're not constantly stimulating the immune system to some degree, low level, the immune system gets weaker over time. So these plant-based foods, healthy in season, appropriately ripened, can have a positive effect in beefing up the immune system from my perspective. It's like lifting weights.
Mhm.
You could argue, Eric, why would you ever lift weights because weightlifting breaks your muscle tissue down? Correct. It does. It breaks it down, creates low-grade inflammation, but that low-grade inflammation then helps me build a bigger, stronger muscle tomorrow. So today, if I have to lift something heavy, I actually have the ability to do it. If I never did anything to strengthen my muscles, I wouldn't be able to do it and I'd probably get injured. Is that fair?
I think so. Yeah.
So I think there's a benefit to them, but I also understand why sometimes when people already have a lot of inflammatory processes going on, they go, oh, I switched my diet and I felt much better. Well,
Mhm.
that dietary switch probably created a big change in your gut biome. And
Mhm.
if you were more plant-based and you already had inflammation and dysbiosis and other things creating disruption there, minimizing some of those plants and plant toxins might calm the inflammatory process, at least temporarily. But I do agree that those short chain fatty acids are critically important, and we'll talk more about that in a sec.
Then there's also the digestive piece and the stress piece as well. because someone
Ah,
can be eating the perfect diet, but they're stressed all the time. And anyone who studies stress knows that when we're stressed, our blood flow is shunted away from our digestive organs, away from our fertility organs, into our arms and legs so we can run or fight. So we can literally flee or fight and survive the situation. Because if you're about to be food for a bear, there's no reason to digest your food in terms of prioritization. The goal number one is get out of the danger zone. And so when that happens once or twice a month, like no big deal. But when it happens all day, every day, and I have lots of clients who are stuck in fight or flight.
yeah, absolutely.
That,
And I talk about, I always look at somebody's physiology from the perspective, is this a person in homeostasis or allostasis? And I talk from the
mhm,
lens of the cell danger response. And that's why on this podcast, in my book, and all the things I talk about, I don't think thyroid physiology is broken. I don't think the immune system's out of control. I think everything is an adaptive response. And so many of our clients are under an excessive stress load. And somebody might
mhm,
say, but I had the same stressors, then this happened, and now I'm back to the same stress load and I can't handle it. Right. Because you had an excessive stress load, you were managing it, you were in homeostasis, but then that extra stressor pushed you into
mhm,
cell stress response. And that shifted you into allostatic regulation. You start upregulating the sympathetic
mhm,
nervous system. Brain gets more wired, more, as you said, more energy, more blood flow goes to the brain and the muscles so we can run. What gets down regulated? Gut physiology, sex hormone regulation, detoxification pathways, these sleep, like all of these things that make us feel wonderful get down regulated, right? And we
mhm,
ramp up the defense mechanisms, and the hormone that helps us regulate the shift from homeostasis to allostasis is thyroid hormone. By decreasing the conversion of T4 to T3 in the cells that are perceiving stress and danger, we actually slow down mitochondrial function. We stiffen cell membranes from a protection standpoint. And that doesn't make us feel good, but that allows that lower T3 state actually activates the cell defense mechanisms inside the cells. So we often look at the low T3 and somebody's like, oh my gosh, your body can't convert T4 to T3 anymore. That is such nonsense, in my opinion. That is the adaptive response. And adding more thyroid hormone in that situation, especially T3, yes, it can give a temporary hit of improvement, but actually can increase the oxidative stress and the inflammatory process that's going on, upregulate the sympathetic nervous system and downregulate the parasympathetics. So I fully agree that stress, right, real or perceived, right? Everybody thinks it's just emotional stuff. It's what you think about your work, your relationships, right? Your
mhm,
partner, like what you worry about, right, on a
mhm,
daily basis. And so many of us, I think, are in chronic perceived stress and we don't even
mhm,
realize it.
mhm. Totally agree. Would you say that for the top five things that cause the cell danger response, stress is one of those top five?
Well, I look at stress as the big category. So,
Oh,
right. So stress is stress. Your cells don't really know the difference. So I look at definitely mindset, like what's going on
mhm,
between the 6 inches of my ears. Cause you know this
mhm,
too, right? I could get yelled at and I could be like, oh man, that person's crazy. It doesn't bug me. Right. Or I
mhm,
could get yelled at and I go, oh my gosh. And now I get angry and that changes my physiology. Right.
mhm,
COVID, you mentioned COVID. The COVID comes, everybody goes inside. Some people stressed, worried. Oh my gosh, my money. What am I going to do? Job, blah, 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 blah. Other people are going, this is awesome. I can work from home. I'm moving to the beach. I'm going to start investing in these different things where they need me. And that person under the same stress situation
mhm,
thrives, right? So it's really not the stuff as much as is can I manage it and how do I
mhm,
perceive it? That's so I always tell people the mindset is one of those top things that create stress. Number two for me is somebody's habits. What do they do?
mhm,
Day in,
mhm,
day out, right? Those things that their habits make or break them. Okay. Number
mhm,
three is sleep fitness. To me, prioritizing good sleep habits, good sleep behaviors, good sleep schedule is critical. Number four, diet. What we
mhm,
eat feeds our microbes, right? We've got more microbes than we got genes. So if we don't feed us well, we're not just feeding us for taste and wow, that makes me feel happy, but we're feeding the microbes. So what we feed them determines what grows. And then my fifth, like foundational, what I call fitness factor is physical fitness. Because I'm sure you know this, physical movement, physical exercise, at the right amount, not excessive, but the right amount can have huge impact on our overall physiology from neurotransmitters, hormones, and gut physiology. So those are my foundational five. I've got 13 other ones I work through with clients from, hey, what's your relationship like? What's going on with your finances? Like all of those things create our body's perception of danger.
Totally. Yeah, you can go into nuance from all of those too. In terms of like diet, also circadian rhythm. Are you eating at the same time every day? Because your body will anticipate the food and will actually start getting digestive juices ready to go, which is why when you wake up for an early morning flight, you're not hungry. And when you eat, then you don't digest as well.
Yeah, absolutely. And so the key piece, I think, for a lot of people when we're running these tests, right, when we're running a gut test, is that the gut Zoomer test or whatever other test they run, it tells a story, but it doesn't tell the story, right? Some people are like, okay, you've got dysbiosis. I'm going to do my gut protocol for the next 30 days, 60 days. And they do. And somebody goes, I feel better. I function better. And then 2-3 months off supplement support, they're like, I'm having problems again. What we see on these functional gut tests is the result of your habits, your behaviors, your lifestyle, and all those things. So yes, we often have to intervene and help this kind of reset itself. But we also, if we don't change the environment, the perceived environment, we don't wind up changing the terrain. And if we don't change the terrain, why would we expect 90 days after all my supplemental support that the problem isn't going to come back? Would you agree?
I totally. Yeah, terrain theory, 100%.
So let's talk. We want to talk a little bit about the digestive capacity, and we can see problems many times on the gut Zoomer test with reduced digestive capacity. But if we had to give somebody some guidance, they get a gut Zoomer test, they see decreased pancreatic enzymes on there, they see fat malabsorption on there. Like, what are things that somebody as a clinician or a client, if the clinician goes over the test with them, what are the things that might be they should be thinking about? Like, why? Like, I always say, look, if you have decreased pancreatic enzymes, I can give you digestive enzyme temporarily, but we got to figure out why. So what are the things that you would suggest just generally when you see reduced digestive capacity? What are the things you want to help inform your clients of, like, hey, here's things we need to consider, or that you're instructing a clinician who's coming for you of like, hey, how do I interpret this thing?
Yeah. So number one, just overall stress level. Are you stuck in fight or flight? On a more incremental segment, like before meals, are you taking some deep, relaxing breaths to get into rest and digest? And then are you actually being with your food and eating your food, enjoying your food? Like when you go to a nice restaurant, you have a drink, you relax, everything tastes amazing. You're like really in the moment. But if you're just eating food to get to the next thing, or you're eating while doing something else like working or studying, which is the worst, like, are you really there with the food? No, it's just going in. The body's like, what are we doing right now? Are we thinking? Are we working? Are we digesting? And so making mealtime a time to just nourish your body and paying attention. Some people call this mindful eating. So smelling the food. I don't know if your mouth's ever started watering after you smell cookies out of the oven. Like that's your body getting a head start on digestion. So smelling the food, really tasting the food, noticing textures, eating more slowly, putting the fork down between bites. If you have a hard time eating slow, maybe eating with a non-dominant hand or using chopsticks, eating with other people, having conversation, anything to slow down the eating so it takes longer. I know in a lot of Mediterranean countries, they'll have like mealtime lasts 2 hours and it's a social event, everyone's happy and enjoying life. Like that's what a meal should be. It should be a time to nourish your body. So if that's not what your mealtime looks like, that would be a great place to start. And then the other component is eating about the same time every day. So you get into the eating rhythm, that circadian rhythm in alignment with when your body anticipates food. So you have the best ability to digest, absorb, and assimilate those nutrients and utilize them for repairing torn muscle tissue or restoring your immune system, for example.
Yeah, I would agree with those things. The other thing I would add to that is you got to chew your food. When we think about what's going to start to cause acids and enzymes to be released, chewing your food appropriately really sets the stage. That's where the food starts to break down in the chewing process. We have enzymes that start to break it down orally. Then from there, we start putting stuff into the stomach, and the stomach acid then gets stimulated, and that should start to break it down. And the downstream impacts of digestion are really based on the acidity of the chyme, the stuff that's leaving the stomach to come into the small intestine. There's sensors there that tell the gallbladder, hey, you got to release some stuff. Pancreas, you got to release some stuff here. If you're just gulping down, throwing some water down on top of it, and that I guess would be the other thing I would say is, hey, don't be drinking. If you're thirsty when you're eating, you're probably not chewing your food appropriately. So do you agree with those pieces as well?
Absolutely. Yeah. And for people who have hard time chewing, look at your teeth, go to a dentist, like get that fixed as well. 'Cause if you have pain in your mouth, it's going to be hard to chew. Missing teeth, anything like that.
Yeah. And I would say, I would add to that too. If you got oral issues and you're struggling with chronic hypothyroidism, thyroiditis, reduced conversion of T4 to T3, what goes on in the oral cavity can be a huge driver of your immune inflammatory issues and your reduced conversion of T4 to T3. Other lab, there's another lab out there I like, and they do a panel that looks at some of the most common organisms that trigger immune conditions and oral bacteria. I can't tell you how many patients who I've worked on my gut, I've done this, I've done that, I've done that. And when we look at their oral fitness through a questionnaire, I'm like, all right, there's some oral, you got some areas here we should get checked out. And then if we do run a test and that, here you go, oral bacteria popped up, I don't have any tooth problems, I don't have any pain, guess what? You got antibodies to these oral bacteria, which means they are creating a reaction. And that also, so the oral cavity becomes really critically important.
Yeah, I had a client who had a cavitation. She addressed it, and all of a sudden she lost a bunch of weight and was able to totally excel in her physical like performance.
Yeah. I have a client 20 years ago. I think she had a wisdom tooth pulled out, and we worked on a lot of different things. And we ran that test, and I'm like, you got positive for oral bacteria. She goes, I don't have any root canals. I don't have any cavities. I don't have anything else. I'm like, well, go get a cone beam x-ray done. The first dentist, I think, just did a regular x-ray. The second dentist did a cone beam. And sure enough, in that pocket was a whole bunch of infection in there. And I'm like, that's why you can't get your immune system stable. That's why your thyroid gland's under attack. That's why you can't convert T4 to T3. Well, what do? You got to get it cleaned out like this. And so it's been a process to do that. But things are oftentimes hidden, even where we don't have signs or symptoms. I want to stay on this kind of theme. So we're chewing, and we need to have appropriate stomach acid. The gut zoomer doesn't have an assessment specifically for stomach acid production.
It does not.
But we do have the next steps. And for the listener, if you have a clinician who's looking at general blood chemistry labs and looking at your signs and symptoms, we can pretty much give you get an idea that you have low stomach acid production. But it's not on this test, because this is really more a functional test further down the GI tract. But there are markers of let's take pancreatic elastase 1. Let's talk about what that is and what should the range kind of look like? And if it is low, what are the common strategies, and what are your thoughts when that value is low?
Yeah, so pancreatic elastase 1 is an enzyme released by the pancreas. It does not get degraded when it goes through your GI tract. So when we measure it in the stool, it's a good representation of how much pancreatic juice your pancreas is releasing in response to a meal. So it's a stand-in. representation of how well your pancreas can release enzymes to help you digest, break down, enzymatically break down your food in order to better absorb it. So when it's low, that's indicating to me that something is not allowing the pancreas to release the amount of digestive juice it needs to break down your food. So why is that? Usually stress, maybe something's going on with the immune system in the pancreas, or I
I'll
mean,
give you,
handful of, yeah,
I'll jump in there and give you some more.
yeah.
One of the things that's really important is there's this thing called a sphincter of Oddi, which is where the pancreatic duct and the bile duct come together, and the sphincter opens up to allow the digestive capacity, these digestive pieces, to come into the small bowel. If you have low stomach acid production, that may reduce the amount of release that's coming in. That's number one. Number two, that sphincter muscle is controlled by the amount of available T3. So if you have low T3 in the GI tract or circulation, that sphincter muscle may not open up as well as it should. And if you have estrogen, excessive estrogen metabolites, estrogen dominance going on, estrogen will also cause that sphincter to be tighter. So it reduces the release of enzymes into the GI tract. The amount of circulating T3 also plays a role in how much pancreatic enzyme is going to be produced in the first place, because you need T3 to support that. So there's lots of mechanisms there. And there's one other one that I've consider, and that is if somebody's in a cell stress response and they've got glucose resistance and they're struggling to produce appropriate levels of insulin to regulate it, there is research that what can happen is some of the pancreatic cells will become insulin producing cells, even though their primary function is to make pancreatic enzymes. The pancreas will say, look, we can't deal with the glucose that's in the system now. We need more insulin to deal with it. And so since more food coming in isn't a priority, let's hijack some of these cells and we'll make them insulin generating cells. And what goes down is the pancreatic enzyme output. So those are some of the things from my point of view.
Oh, I can tell you're the thyroid expert, Dr. Balcavage. Like, I did not know that a hormone like estrogen dominance can slow down digestion, because that happens so often.
Mm-hmm.
And the gut
Yeah,
tumor has this marker called beta glucuronidase, which also could be contributing to estrogen excess. If you're not making too much, you might just not be eliminating it.
yeah. And so, but these are the things, like when I'm going through the tests, and I think it's important when somebody's running this test, right? We can't just read it.
Mm-hmm.
We have to interpret it, right? Just
Yeah.
like blood work. People are like, oh, it's outside the optimal range, therefore you need this. Or it's inside the optimal range, so therefore it's good. Well,
Mm-hmm.
no, it's not. If you have hypothyroid signs and symptoms and your TSH is normal, that's totally inappropriate for you, right?
Mm-hmm.
There's reasons why that TSH may be suppressed. Same thing when we look at these tests, right? And we look at this gut zoomer and we see these things. A lot of those patients, and I'm guessing you would do the same thing. There's decreased pancreatic enzyme output. Let's support with a digestive enzyme
Mm-hmm.
right now, but that's not the long-term strategy. The long-term strategy is to get the
Mm-hmm.
pancreas to actually release this stuff more appropriately.
Absolutely. It's short-term symptom reduction mechanism. And then meanwhile, we support in order to return you to homeostasis.
Exactly. What about the bile physiology component of this and the fat malabsorption? Can you talk about that a little bit?
Yeah, so Vibrance Gut Zoomer measures several bile acids, two primary, two secondary, and then it gives you the ratio as well.
Mm-hmm.
So we're looking to see, are you properly converting the primaries into secondaries? Are you able to reabsorb bile because we utilize it multiple times, it gets recycled? Is that happening? And then we also look at fecal fats to see and affirm, like, if there's fat, if there's elevated fat in your stool, if you have floaty stools and oily stools, it indicates you're not able to digest and absorb your fats, your fat soluble vitamins, your omega-3 fatty acids, the stuff that helps with proper, like, healthy skin and eyes and brain development. So it looks at all of those things as well.
So if somebody has on the gut zoomer test, they've got multiple markers of fat malabsorption, but their bile acid percentages, their metabolites are normal. Do they still have a potential bile, gallbladder, liver issue going on?
Oh, good question. So they could have just had a really high fat meal and their body just couldn't handle it. Or, the percentages may be okay, but it's percentage, it's not actual amount. So it's not telling you if there's enough of it or not. It's just showing you the ratios of primaries to secondaries.
Correct. That's what I would say too, because I've had patients that I've gone through the test with them. And they're like, you said I had a problem with bile and physiology and fat, but the bile acid metabolites are normal. Right. Those are percentages. That doesn't tell us total circulating. And my opinion, you correct me if I'm wrong, we're looking at the primary bile acids are when you eat, your liver releases bile acids that are already ready from your gallbladder. And then those bile acids are being recycled 5-6 times through the meal. And most of those primary bile acids are being cycled through the system. We're looking at the primary bile acids on there are CA and CDCA that are on that form. There's a very small percentage of primary bile acids that make it to the colon, about 5% of the bile acids. And then we're looking at the secondary bile acids. And to me, what this really gives us an idea when we look at the bile acid metabolites is how well are those bile acids being resorbed? Am I getting too much moving down that track and getting into the colon? And then it gives us a little bit of a story about what's happening with the colonic bacteria and how they might be converting those. And there's another little nuance that's important here, and I won't get too technical on it, but thyroid hormone plays a role in which bile acid percentages we see on there. So when I see somebody based on their medication, I might see an alteration in the percentage of CA or CDCA, and that's it being influenced by the amount of T3 that's getting to the liver, because that changes those a bit. So that's how I look at it. So when patients say, but my bile acids metabolites look good, I'm like, that's part of the picture. But the thing that we're more concerned about to say, hey, is there fat malabsorption issues here and bile issues and pancreatic enzyme issues, is when we look at those fecal fats, right? Because if you're eating fat, sometimes people say, well, maybe I just eat too much fat. I don't know if that's necessarily the case, but a lot of people just don't have great bile flow. I mean, and if we look on that test and we see low pancreatic enzyme output, then there's a good chance that we're going to have some fat malabsorption, correct?
Yeah, and it takes bile to move bile. So sometimes if you have sludgy bile, just giving a bolus of like TUDCA, taurodeoxycholic acid, that can get it flowing again.
Yeah. And let's talk about, we're going to talk about intestinal permeability here in a bit, but this right here, we talk about where we're at with this fat malabsorption, we're talking about bile, that too plays a role in when we're going to talk about permeability and intestinal permeability, right? So I don't know if you want to touch base on the role of bile acids in maintaining those tight junctions, or do you want me to take that?
Why don't you give it a stab?
Absolutely. So bile acids, just so everybody knows, bile acids, these things don't just break down fats. Bile acids are antimicrobials, direct antimicrobials that top into the GI tract. They start killing the bacteria that makes it past the oral cavity, makes it past stomach acid. It starts entering into the small intestine. Bile acids are there. They start breaking down biofilms and doing that stuff. As those bile acids move down the GI tract and are absorbed through the intestinal cells, the bile acids actually help maintain those intestinal tight junctions. And we're going to talk about something else that's really important on this test that helps us get an idea of intestinal tight junctions. But that bile helps regulate healthy tight junctions. So if you don't have good bile flow and you have fat malabsorption, more than likely, you're going to start breaking down the intestinal barrier and leading to potentially what we call intestinal permeability or leaky gut. Those bile acids at the end of the GI tract also activate some of the things on the inflammatory panel, the beta defensins and other things, to help deal with the bacterial overgrowth and prevent it. So if you don't have good bile flow, you don't kill bacteria coming in from your food or your oral cavity at the top end of the GI tract, and you can't control the bacteria as well at the bottom end of the GI tract. Did I miss anything?
I think you got it.
All right, fantastic. So let's talk short chain fatty acids. What are these things and why are they important?
Yeah, so short chain fatty acids are going to be the postbiotics made by your commensal bacteria. So they're turning mostly carbohydrates into these short chain fatty acids. You can also have putrefactive, um, not short chain fatty acids, but the proteolytic versions where it's breaking down protein, like fermenting protein, and those are not as good. But the short chain fatty acids from carbohydrate, saccharolytic fermentation, that's going to create these byproducts that are very beneficial to the body and helps heal and seal the gut, helps repair the gut barrier, helps signal to the immune system, just in general, really good things.
Yeah, the short chain fatty acids, really important for people with immune dysregulation. You're about 70, we think the literature says maybe about 70% of the immune system surrounds the GI tract. And that's why we're all kind of look at the GI tract when we're saying, hey, there's immune inflammatory problems. We got to have a healthy gut. Everything's got to come in through the gut. Everything's got to come out through the gut. And there's such a signaling mechanism to the immune system. Interestingly, there's a direct lymph connection from gut to thyroid for everybody, just so you know, if problems in the gut can directly impact the thyroid from a lymph perspective, not just a blood perspective, but a lymph perspective. But the short chain fatty acids are a huge driver to upregulate what are called the T regulatory cells. So if you have an immune inflammatory process that gets started, we want that to happen. We want the immune system to defend us. But if you don't have healthy short chain fatty acids, the off switch may not be there to calm the whole process down. So once that thing gets turned on, if you don't have the right bacteria, you don't have the right diet, the right bacteria to produce these short chain fatty acids, you may initiate an immune response, but it may be hard to turn that off. Are you okay with that? You saying that?
Yep, that all makes sense.
Perfect. So if somebody there's a lot of times when people say, I eat a lot of plant-based foods, why would my short chain fatty acids be low? What's your take on that?
Huh. Good question.
So my take when somebody tells me that, I'm like, look, there's a couple pieces here. What you put into your body is going to have an impact on the bacteria that grows. If what you're consuming, even though you eat a lot of plant-based foods, if they are more process-based foods or more alcohol or more sugars or other things that actually prevent these bacteria that take these short chain, the fibers, and convert them into short chain fatty acids. If those are down regulated, you could eat all the plant matter in the world and you're not going to produce the appropriate short chain fatty acids. Are you okay with that?
Yeah, so when you said plant-based, what I'm thinking of is whole foods. Like I went to Bastyr University School of Holistic Medicine. So when I hear plant-based, I think of like carrots and apples and almonds and black beans and brown rice and quinoa. I don't think of like a vegan thing that's full of
Well,
a processed food. Like
yeah.
totally. It's you have to eat real food. You have to eat food that's from nature. Like you can recognize it. Your grandma you could cook it in your own house. Like that's the food that fuels and feeds us. It's not the convenient stuff that lives on a shelf for 12 years.
And is it fair to say that the perception of life-based stressors could potentially change the bacterial balance? So therefore, even that whole food-based diet is great, but the bacteria are being altered by the stress response. So they're not there to really at a high enough level to produce these things.
Absolutely.
Yeah.
Absolutely. And we know that stress reduces your secretory IgA as well, which is part of that barrier. It's part of the defense. It's like the guards around the castle. When you have low secretory IgA, it's like they're sleepy and they don't really protect you another
Yeah. So that's another thing that's on here. on this test, and I think it's an important marker. So let's talk about what secretory IgA is. I think it's important that people know what it is. And then if it's low, what should that be telling us? And if it's high, what should that be telling us?
So secretory IgA is a type of immunoglobulin. So we're looking at the immune system. And there's a sweet spot in the middle where you want it to be. If it's too low, it means your immune system isn't able to fight against a pathogen. It isn't able to fight against the neighbor that's doing naughty things. But if it's too high, that means it's actively trying to fight against that pathogen. It's actively trying to fight against something that's causing dysbiosis in the gut. So we want it optimally to be at that normal level. And not on either side. Although it's probably easier to treat the high side because you identify what it's fighting against and then get rid of that, or adjust the diet, lifestyle, all the things to balance it back. It's a little bit harder to bring it up if it's low because that's usually indicating you've been under stress for a long time and it takes a while to bounce back.
Yeah, I want to come back to that from a testing perspective, but I, I I see this as well. Like I think the same way. Like if we see dysbiosis and inflammation,
Mm-hmm.
I'm hoping that the secretory IgA is elevated, right?
Mm-hmm.
Somebody be like, well, why would you want it high? Listen, if somebody's breaking into your home, I want the cops. I want lots of them, right? I
Mm-hmm.
want
You
them
want some
coming.
harm
That
scale.
tells me that your immune system is appropriately responding. If you have a lot of inflammation and you have low secretory IgA, I'm worried that you don't have an immune system that's capable of dealing with it, and we really need to help out. And not only
Mm-hmm.
does the secretory IgA influence your gut physiology, but all of your mucous membranes. So all systems, nasal
Mm-hmm.
passages, oral
Mm-hmm.
cavity, eyes, pelvic area, right? Like everywhere where you have these mucous membranes, these coatings, these protective coatings of that kind of as a barrier from outside to inside, the
Mm-hmm.
secretory IgA system is the police force there, right? So if they're weak, you're more susceptible to chronic organisms getting into the system and becoming latent or active or acute or replicating infections. But more oftentimes what we'll see is that these are people with chronic latent infections. They're not in a replicating mode where like, oh my gosh, I got a fever, I got chills, I got all that, but they have chronic health, low-grade health
Mm-hmm.
issues because the organisms are like, nobody's stopping us. Let's go. I would do the same
Mm-hmm.
thing, right? Well, there's nobody to stop me from walking on the private beach. Great. I'm going to go on the private beach. Why not? Right. So secretory IgA is critically important from when we assess that, because that really
Mm-hmm.
does tell us like the state of the immune system, right?
It does. Yep.
We're going to come back to maybe rechecking this and maybe some strategies here, but zonulin. There's a lot of discussion about zonulin, fecal zonulin versus zonulin antibodies. Some people say fecal zonulin is not a good marker of intestinal permeability. They say you got to run blood tests and antibody tests. Other literature says fecal zonulin can be used. What's Vibrant's stance? I would say they would believe that it can be used as a potential marker of intestinal permeability, but what's the general thought process regarding fecal zonulin? Let's start with what is fecal zonulin,
Mm-hmm.
and if it's elevated in the stool, what does that mean, and how does that maybe differ from blood testing? If you're good with that.
Yeah, so I like to think of zonulin as like the key that unlocks the tight junctions. So when there's zonulin present, it means the tight junctions have been told to open up. It's like open sesame. There's actually a study by Dr. Alessio Fasano that talks about this. It's called Open Sesame. So zonulin opens a tight junction. So when you see zonulin in the gut, it means that sometime when that stool was formed, zonulin was released, the tight junctions opened. So there has recently been, depending on how long it takes you between stools, it recently has been leakiness in your gut.
Mm-hmm.
The reason we would also do a blood-based test is because we look at zonulin antibodies.
Mm-hmm.
And zonulin antibodies provides a snapshot, or sorry, a report card of how long and how often zonulin's been elevated. So whereas like zonulin, just zonulin and a blood test will tell you if it's actively elevated, like a fasting blood sugar, like what is it right now? A anti-zonulin is going to give you a report card. If it's IgA, it's like the last week. If it's IgG, it's maybe the last couple of months. It'll tell you how often it's been elevated over that time period. It's like hemoglobin A1C. It gives you a past perspective.
Yeah.
And they can both be helpful in hand. But if you have elevated zonulin in your stool, it means you had elevated zonulin before you in creating that stool.
Yeah. So I think, like, I see both sides of the argument, but it's on here. When we start to see it elevated, like, if you don't have antibodies yet, that doesn't mean we don't have a problem.
Right.
Right. We got an issue we need to address. We got to reduce the inflammatory process. We got to deal with the dysbiosis. We've got to support proper bile flow and short chain fatty acids so that we have less breakdown of the barrier. If we don't do that, whether you have a positive antibody test or not, you're probably going to have one.
Right.
Is that fair?
Yeah. I mean, and lots of things can trigger zonulin release. So there's evidence in the literature showing gluten exposure can cause it, showing LPS bacteria can cause it, alcohol causes leaky gut.
Don't tell everybody that. No, I'm just kidding. No, but there are so many things that do it. That's why we promote like whole food, anti-inflammatory, low processed style diet, right? Not necessarily restrictive diet. My opinion is restrictive diets are short-term temporary options, but long-term, we want to be whole food based. Mediterranean style diet is probably a great place to be if you had to think, but whole food based, low processed food based diet is really, my opinion, the gold standard. And I think it's 80-20. And I try to explain 80-20, 80% good habit, 20% bad behavior. If you do that consistently with all of what I talk about, all the fitness factors, you're probably going to be fine. If you have 20% good habit and 80% bad behaviors, you're in trouble. You're going to have problems. So fecal zonulin, if that's elevated, that tells us we're running the risk to develop more intestinal permeability. And let's talk about what that might mean for activating the peripheral immune system or inflammatory system.
Yeah, so usually your tight junctions or your the cells in your gut are really close together, which provides a barrier. So things in the gut lumen, the stool doesn't get into the bloodstream. When the junctions are leaky, that means things in the gut lumen get towards the lamina propria where there's immune cells, and the immune cells get activated more often. And when the immune cells are activated more often, that means you're going to have more inflammation.
Yeah, and the other thing, go ahead.
And it's systemic. It will manifest wherever you're most genetically susceptible. So it could be joints, arthritis, could be Hashimoto's thyroiditis, could be dementia, could be just brain fog, could be fatigue.
Yeah, those inflammatory molecules are going to set the stage for problems, right? Tissue damage, we get upregulation of the immune system. When those tight junctions become more permeable, poorly digested food matter. When we eat food, we break it down, especially the proteins, from a big structure to a smaller structure we call a peptide, and from the peptide into what we call amino acids. And the amino acids are really what's meant to be absorbed across the GI barrier. But if we get higher levels of peptides crossing the barrier, that can start to trigger more immune type reactions. If we have LPS you talked about, that's the coating of gram-negative bacteria. You have gram-negative bacteria, it's supposed to be in the GI tract, but the gram-negative bacteria, if particulate of gram-negative bacteria or the bacteria itself crosses that barrier, the immune system is going to become activated. We call those PAMPs, pathogen-associated molecular peptides. If there's damage to the intestinal tissue and part of that enters into the bloodstream, we call that DAMPs, damage-associated molecular peptides. And those things activate the immune system. The DAMPs say, hey, it's me, the gut that's damaged. The immune system goes, oh, we got to go to the gut. If there's PAMPs, they go, those bind to the immune cells and say, hey, this is the thing we're looking for. Go find it and kill it. From a thyroid perspective, I want to make sure everybody hears this piece. We think that a lot of times thyroiditis, you'll see it written up because it's gluten and you eat gluten and it causes cross-reactivity or molecular mimicry. But what's often not talked about, I talk about it a bunch, is that the thyroid cells themselves have pattern recognition receptors. That means not on immune cells, these PAMPs and DAMPs, these danger particles attached to the immune system to immune cells to activate the immune system, to tell it what's the problem and where the damage is so they can help. But the thyroid gland has pattern recognition receptors. And this is why I said I don't think thyroiditis is a mistake. I think it's an adaptive response, because if those PAMPs or DAMPs bind to the thyroid cells themselves, the thyroid cell now becomes an immune-like cell and initiates the release of inflammatory cytokines, inviting more lymphocytes into the thyroid gland and creating more damage. It's not broken physiology, because that process can turn back off. But if you think about it from my perspective, if the cell that's under stress and danger is trying to downregulate its metabolism, it can do it locally. If there's lots of cells and tissues in a systemic inflammatory or danger perspective, how does the body slow down the metabolism? You slow down the production of the primary hormone that drives metabolism, and that occurs at the thyroid gland. And this is why I say thyroid gland hypothyroidism is oftentimes recoverable, but we have to address the things that are creating this immune activation. And you're right, those immune inflammatory chemicals, those DAMPs, those PAMPs, they can create other tissues to be damaged in time. But a lot of times I don't think of it as just like, okay, the immune system is going to damage the tissue. I think it has something to do with alterations of the local proteins, structures, because of some of these things, damage being done, and then the immune cells kind of scooping up a debris field and going, oh, there's an organism here or a piece of something and a piece of tissue. I knew what the tissue was. I don't know what these two things are combined. And now, because of that leaky gut and that LPS being out, now the immune system says, well, I'm going to react to what was connected to that piece of material.
Yeah, totally.
So we're going to wrap this up, because I'm sure you've got other things to do than listen to my boring voice, right? But there's one more thing I want to cover on the test, and that is fecal anti-gliadin. Okay. Now, a lot of people who've already been in the functional medicine space are gluten-free, dairy-free, and they get a test done like this, and it is positive. And they're like, I am not eating wheat. How can that be? How would you explain that to somebody, why their fecal anti-gliadin might be elevated despite not consuming it? Because that, in some people's mind, until I explain it to them, they think the test can't be valid because I don't eat it.
Oh, totally. This happens all the time. One, there's a lot of cross-contamination. If anyone eats out, you have no idea what's happening in the kitchen. Most fried things, there's cross-contamination. French fries, they're probably also frying corn dogs covered in wheat. You're getting gluten exposure there. Like, it just happens all the time. Vegetables, they'll fry those too. That'll be covered in gluten. So you really have to ask, do you have a dedicated gluten-free fryer if you're going to eat anything that's been fried out, period, full stop. Also, just things can happen in a kitchen. Like, if it's not your kitchen, you don't know. You really don't know. Other times there's just lack of understanding of what is gluten, what's not gluten. And then we also, I had a client who lived just down the road from a wheat field and was inhaling gluten antigen all the time. Had to move.
Is it possible that somebody with poor digestion and permeability and eating other grain-like foods could have their immune system that has become reactive or responsive to gliadin or any of the wheat peptides, see a piece of poorly digested plant protein, let's say corn protein, and say, you know what, that looks close enough. In this chaotic situation, I think that's wheat.
It's a good question. I suppose it's possible.
This is where they talk about molecular mimicry or cross-reactivity. So I don't know if the gut Zoomers test is more specific, that it factors that piece out.
I know that our blood test is, because we manufacture the exact peptides and proteins on our immunochip on the silicone semiconductor wafer. And so I know it's specific to that thing. And I know antibodies are very specific to this thing they're attacking. But yes, absolutely, molecular mimicry can happen. It does happen. That's how we get Lyme arthritis, for example. Um, that's how we get rheumatic fever, I think it is, where you get anyway. Um, so yeah, possible. Oftentimes when someone is reactive to the non-gluten wheat peptides on Vibrant's wheat zoomer, they also have reactivity to other grains like corn, rice, etc.
And the antibodies on this test, they're secretory
Mhm.
IgA antibodies?
There are not. It's just looking at the level of secretory IgA.
No, so the anti-gliadin, which antibodies
Yes,
are being tested?
a gliadin.
Right. Is it IgA antibody testing or IgG? It would be IgA,
It's
right?
got to be IgA because that's what's made on the mucosal surface.
Right. So, because that leads to the next question,
Yeah.
right? Which is,
Mhm.
I eat gluten, I'm
Mhm.
within the reference range,
Mhm.
therefore I'm not reactive to it. And I always tell people, look, it all depends on where you're at, and it depends on
Mhm.
what that secretory IgA level is.
Oh yeah.
So if you're 100, but your secretory IgA is 300 and reduced and suppressed,
Mhm.
then we're not really seeing your full response to gliadin. And I could be totally wrong, but that's how I explain it. Does that make sense to you?
Yeah, I mean, I would test total immunoglobulins in the blood to look at total IgA, total IgG, total IgM, total IgE, because that's going to give you a better snapshot. Secretory
Mhm.
IgA is similar but different. It's a different than a total, like than an IgA molecule. But yeah, they should, I mean, sometimes they correlate, sometimes they don't.
But if we're looking at fecal anti-gliadin, we're looking at antibodies to gliadin,
Yes.
right? So
Mhm.
if their immune response, and we're just looking at the test,
Mhm.
and the gliadin is with if it's within the reference range, but the secretory IgA is weak, does
That,
it?
I mean, if it correlates clinically, absolutely, you could
Mhm.
indicate that for sure.
Okay,
I mean, even just a slightly, like if it's in the green, but it's high green, that means something too.
sure, yeah, you're still responsive, right?
Yeah.
Yeah.
It
Um,
doesn't, it's not zero. It's not at the very low end. It means there's some reaction. And is it
mhm.
a some reaction, but would have been higher if your immune system was more robust? Or is it, right? What's the reason for it to be a high green, high normal?
Right. I agree. And
Mhm.
that's where it comes down to the interpretation piece, right? Not just saying,
Right.
oh, it's in the green, you're
Mhm.
good, but saying, how much do you eat? I don't eat much. And it's this high in the green. Hmm. And
Yeah.
maybe your immune system's compromised.
Mhm.
You might be. And you guys are only testing one peptide on here,
Correct. Yeah.
right? And there's
Mhm.
multiple breakdown products
There
of
are.
wheat. So the
Mhm.
important part is if you feel wheat reactive, but this component is normal, it doesn't mean you're not reactive, right? You
Right.
might be better to look at an antibody test.
Mhm.
Yes, and we'd look at maybe the breakdown, all the breakdown products, and see,
Mhm.
are you reacting to other components of wheat, but not this
Yeah.
gliadin piece that you're looking at here.
Like when there's scattered thunderstorms, you might be in a sunny spot. Doesn't mean it's not raining somewhere else in your body.
Yeah. Perfect. All right. So let's wrap this up. Let's do two things. What, if you wanted to give some final insight into the benefits of the gut zoomer test, maybe over some of the other tests that are out there, and then maybe 3 tips for somebody who's struggling with chronic GI issues. Should they run a test? Should they not run a test? When do they run a test?
Mhm. Yeah, so Vibrant's Gut Tumor is just very comprehensive. It includes more microorganisms and more of these extra markers to look into digestion, absorption, immune response than pretty much every other test, any other test on the market. Um, in terms of whether or not to run a test, I'd say everyone could benefit from gut tumor testing. Everyone can benefit from knowing what's going on in the microbiome. Um, and then in terms of when to test, I would definitely not do it right after colonoscopy because that will wipe out everything in your gut. So wait at least 2 weeks for the microbes to grow back
Mhm.
And as a side note, after a colonoscopy is a great time to feed your microbes all of the healthy things so they grow back in the way you want them to, as opposed to eating a poor diet, which then would continue to decimate them. So not right after colonoscopy. And then I would do it eating your normal diet. Some people, some providers will say avoid anything that could possibly contribute to a change in the gut, but you want to do a baseline, or you want to do like in your normal, like, like washout, or just like eating your normal, what does that look like? So I would say maintain your normal routine, which you're currently doing. I would not change anything personally for my clients to just eat normal. Um, and that will give you the best insight into what your current diet, lifestyle habits, what impact that's having on your gut microbiome.
And I agree with that. Like, I don't want to test you on your like 2 weeks on a AIP diet. That
Right.
doesn't tell you were
Yeah.
struggling with on your diet. I want to
Right.
test you on your diet.
Yeah.
Last question.
Mhm.
So many people taking supplements.
Mhm.
Okay. So they're taking lots of supplements.
Mhm.
How do you recommend? I give different answers here based on the individual. But should somebody, if somebody's testing doing the test, are there
Mhm.
supplements that are going to interfere with the test that they shouldn't take?
Mhm.
And if somebody's coming in, I'm taking this probiotic, that probiotic, I'm taking this, I'm taking that, taking this. Do you have them stop those things, or do you have them take those things? I'd like to get your opinion on that.
Yeah. So if you want to know if your gut needs a particular supplement, I would say test without the supplement to see what it's doing baseline.
Mm-hmm.
I think baseline information is more helpful because if you're taking, digestive enzymes, if you're taking prokinetics, if you're taking probiotics, like that's going to impact the results.
Mm-hmm.
And it might say, it looks great, but that means maybe you need to be on digestive enzymes the rest of your life, or taking that probiotic the rest of your life. But that's really not sustainable. We want you to be in homeostasis without the need for extra stuff. It's a supplement because it supplements. It's not a long-term
Mm-hmm.
thing that you have to do all the time. So I love like just baseline, no supplements.
Yeah, I agree. So I'll tell most people, listen, I don't want, if I can get them all, my starting point is usually you're on 30 supplements. If you need 30 to feel this awful, you don't need any of them. Let's wean you off of them first. But
Yeah.
if I have somebody who says, listen, this is a really good probiotic, I'm taking this, I need my digestive enzymes, then I may, if they're not willing to not do those things, I'm like, great,
Mhm.
take it, because I want to show them that what they're doing isn't having the intended
Mhm.
impact they think it is, right?
Right.
And so typically I'd say, look, don't take anything, a week or so, and then we'll get the stool test done. Just eat your normal diet. We don't need all the extra support in there, and let's just see where you're at. But if somebody says, I can't live without it, great. Take your stuff. Let's see how it changes. See how, if it makes the test look perfect, then we know there's problems, and what you're doing is managing it. But then we have to talk
Mhm.
about whether you want to recover or you just want to manage. But many times the reason they're coming to you or I is because they they're managing their symptoms with supplements, but it's not really
Mhm.
restoring a healthy functional
Yeah.
state.
No one goes to a doctor if they're feeling great.
Yeah. So Adair, I want to wrap this up. I want to respect your time. We got like 2 minutes left. So tell everybody a little bit about you and where you're located. So if they want to hear more about you and what you do, they can reach out.
All right. So I'm located in Washington, D.C. My private practice is called Eating with Integrity. The website's www.eathonest.com. You can schedule a free consultation to learn if my program is right for you. Um, and I resolve functional gut disorders like IBS, so helping people be able to live a normal life again after
Awesome.
suffering from all the digestive issues.
Awesome. Well, I appreciate you coming on the podcast. We got through a lot of this test and some of the markers on there and the importance, but I appreciate you coming on and sharing your wisdom with us. All right.
Thanks for having me.